Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the Q&A pod located to the right of your webinar platform. It is now my pleasure to turn the conference over to today's first presenter, Ms. Beth Kenefick. Ma'am, please begin.
Good afternoon, and welcome to the webinar, Financing Community Health, Unlocking Investments to Address the Social Determinants of Health, hosted by the American Hospital Association and its affiliate, the Association for Community Health Improvement. My name is Beth Kenefick, a program manager with the Population Health Team at the AHA and ACHI, and will be moderating this webinar today. A quick roadmap of the next 60 minutes is as follows. I'll be leading us through some quick introductions before passing the baton to our speakers from the Center for Community Investment and Kaiser Permanente. We plan to keep the last 10 to 15 minutes open for Q&A before we wrap up. But first, we invite you to mark your calendars for the Association for Community Health Improvement's 2020 National Conference in Cleveland from June 15th to the 17th. The ACHI National Conference convenes over 700 population and community health professionals to learn from experts and exchange the latest tools, approaches from the field. Attendees will have the opportunity to participate in interactive workshops, site visits, breakout, and plenary sessions. Collaboration and connection to advance health equity are the focus at the ACHI 2020 National Conference. Population and community health leaders are coming together to look at community health, and health equity through one lens, sharing innovative strategies and new tools to tackle tough challenges, and boldly transform how communities and populations experience health and care. We're excited to announce that in 2020, we'll be partnering with the AHA's Institute for Diversity and Health Equity on programming around this topic, and we'll share the stage with them on some key sessions. Their conference will end the week from June 17th to the 19th, and you'll have an opportunity to register for both at a discounted rate. I'm excited to share with you the speakers today. Robin Hacke is the Executive Director of the Center for Community Investment, which is dedicated to overcoming disinvestment and improving opportunities so that everyone has a fair chance to lead a healthy and productive life. Working with the cross-sector partnerships, innovative health institutions, and local leaders, CCI helps communities unlock the capital they need to become more cohesive, resilient, and environmentally sustainable. Don Vu is the National Vice President of Strategy for Community Health at Kaiser Permanente. He is responsible for providing leadership in the development and implementation of key strategies to help deliver on Kaiser Permanente's commitment to improving the health of communities. He has been with Kaiser for over 20 years, having previously been a director in national strategic planning. Before we get started, just to get a better sense of who's on this webinar, we invite you to look at the poll at the bottom of the screen and answer what role most closely resembles your own. A, community benefit. B, population health. C, community health. D, community and government relations. E, clinician. F, philanthropy. G, academic researcher evaluation. H, public agency staff. I, consultant. J, nonprofit partner. Or K, other. We'll give you just a moment. Great. It looks like we're having about 35% in community health, 19% in community benefit, 12.7% in population health, with a number of other folks across the rest of the answers. Before I turn it over to Robin, I just want to remind you all that you can submit a question on the question screen on the right hand of the presentation. And with that, I will pass it over.
Okay, terrific. Well, thank you so much. It's really wonderful to be with so many of you, and I'm really excited to share this material. We all know that where we live profoundly affects the opportunities that we have to get a great education, to be safe, to buy healthy food, and that all of this matters for health. Some health systems are beginning to think really deeply about how they can get beyond their own institutional walls to make a difference in their community. And the work that I want to talk to you about today is learning that we have been doing along with those innovative health systems, including John, in a program called Accelerating Investments for Healthy Communities. I'll talk more about that in a moment. So the social determinants of health in a place are the result, as we know, of decades of decisions about how we as a society invest our resources and decide to treat people. In many places, the structural racism that has been baked into our systems for many years has created places of concentrated poverty. Well, it turns out that mainstream finance doesn't really work so well in places where disinvestment has occurred because markets in those places are not functional and therefore capitalism is not really built to do that. So community investment, which is what we'll be talking about today, was created as a way to direct investment to the places where disinvestment has occurred. And over the last 50 or 60 years, the community development sector has been working on figuring out how do we get resources to the places that they wouldn't otherwise go. As we see health systems take a greater interest in those social determinants of health, they have the opportunity to both leverage and contribute to the community investment sector, and that's what we'll be talking about today. So it turns out that hospitals and health systems tend to think first about their community benefit pot of money as the resources that they can use to address community health, and those are certainly critical resources for reasons that we'll discuss. But it's not really the only assets that they have. They have their endowments, they have their insurance reserves, so there are other types of financial resources. But they also have their land, some of which may turn out to be surplus or underutilized. They have their expertise, not only in medicine, but also in development, in communications, in community relations, and other fields. And they have a set of powerful relationships with the public sector, with other institutions, with philanthropy, all of which can be leveraged very successfully to move the needle on community health. So one of the things that we'll be hearing from John, and also that I'll talk about in the context of our Accelerating Investments program, is how can hospitals and health systems really bring together these different assets in the most powerful way to make a difference. So before we do that, let me just spend a minute on why would health institutions do this. One obvious reason that health institutions invest upstream is that it pays. You can generate financial returns for your system, both in the form of interest or return on investment, but also in terms of avoided costs or savings that can be really meaningful. And especially as the shift from volume to value gathers steam, that can be an important motivation. But what we found is that it's far from the only motivation, and it may not even be the most powerful one. What we've seen in the health institutions that we've been working with for the last couple of years is that there are a number of other motivations that really affect how systems do this work, to what extent they do it, and what kinds of interventions they choose. So the first one, which really tends to be a big deal, is that we see a trend in the field towards redefining mission from the provision of health care, clinical services, and towards the assurance of health. And as soon as we do that, as soon as a health institution redefines its mission in that way, it wants to spend its resources on the things that are going to make the biggest difference for community health. And it's clear, as the research shows, that social determinants, the conditions in which people live, really do matter for health. So that's a powerful motivation for doing this work. Another one, which is maybe a little less noble, but really quite important, is that health systems and hospitals depend for their success on all kinds of approvals that come from the public sector. And right about the time that you're going to build a new facility or open a new service or ask for approval of a merger, turns out to be an excellent time to really be interested in what the mayor cares about. And often the mayor has a pet project, whether it's affordable housing or some neighborhood that is in need of revitalization, that is really a shared interest between that important elected official and the health institution. Important not just because we want the zoning variance or we want the approval, but because it is going to make a difference for the health of our community. So that turns out to be a powerful motivator as well. And related to that, what we're seeing is an impact on the competitiveness and long-term health of an institution. So if you're in a neighborhood that staff or patients don't feel like going to, then that is a real negative for the institution. On the other hand, if the institution develops a practice of community investment that contributes to its reputation, contributes to the strength and health of the neighborhood, and also, by the way, gets you some points on requests for proposals by government payers or other contractors who really care about these things, well, that's a win for everybody. So a lot of motivations for doing the work. They can all be in play in the same institution at the same time. They tend to be distributed not so equally among different departments. And so the more departments that get involved, the more motivations you can tap, and sometimes the deeper resources will be available. So now what I'd like to talk about for a few minutes is what does it mean for a health institution to leverage its assets to do this work? So you're going to get a 5-minute introduction to basic finance concepts to help you really think about what's the potential that you have to make a difference using these tools for community health. So I'm a reformed investment banker and venture capitalist. And in the 12 years that I've been doing community investment, what I found is that there's some real confusion about terminology, which will take 30 seconds to clear up and will prepare you to talk to your chief financial officer. And so that is what we're going to do now. The difference that I want to emphasize is a difference between spending and investment, because we have a tendency to use what we call poetic terminology, like we're investing in the future of our children, obviously a wonderful thing to do. But when the CFO uses the investment term, that's not what he means. What he means is investment that generates some form of monetary return. And that can be interest, it can be capital appreciation, it can be savings, but money goes in, money comes out, it's a financial deal. We differentiate that kind of financial investment from what in regular English we would just call spending, which can be incredibly worthwhile and important, but it's different than this kind of money in, money out model. So you spend on programs, you spend on salaries, you spend on things where you don't have an expectation that the money will be repaid. And differentiating between this kind of poetic use of the word and the financial use of the word can just help clarify what our expectations are. And it has been my experience that CFOs really appreciate that. So why do we need to learn enough about finance to talk to the CFO? Well, if we have big social goals like creating health equity, improving community health, that turns out to be too consequential to just leave to the people who care only about financial return. And so understanding enough to be able to have the conversation, ask the right questions, and use your values and money to unlock a greater amount of investment from others turns out to be, I think, a really important thing. So we say an educated consumer is our best customer. So when I say that we can get more money to flow to the things we care about, how does that work? I don't want to underplay the importance of grants. Grants are magic money. They can do anything. They can do spending. They can do unlocking of other people's money. So why would we bother with anything else? The reason that we would bother is that the scale of grants is never going to be sufficient to address the scope of challenges that we're interested in. And so man does not live by grants alone. If you can use your grants strategically to bring money in from others, which is what we're about to talk about, then you can go from only referring people to affordable housing, for example, to building more units. You can go from supporting a food bank, obviously very important, to figuring out how to finance a grocery store. These things don't come at the expense one of the other. They come as complements one to the other. So I'm not suggesting that investment can do everything. It certainly can. But grants can be used in a strategic way to get many, many more investment dollars flowing, which if we're looking at the social determinants at scale, really matters. So how do we do that? The way we do that is by recognizing that money comes in flavors. And if you look at the bottom of the little ball, you see some of the flavors that money comes in. On the left-hand side, the grant money is money that can do anything, infinitely flexible, requires no returns at all. On the right-hand side, you have what finance people would call risk-adjusted market rate money, which means I sure expect to get paid in proportion to the amount of risk that I've taken and as much as anybody else in this situation would want. So those two things are kind of the extremes. And what you see in between on that spectrum are types of money that are making trade-offs between financial return and social return, or sometimes what's called double bottom line investing. And depending on how far to the left or the right the particular form of finance is, that trade-off is either deeper towards impact or deeper towards finance. So community investment works by recognizing that not all investors are the same, and that by kind of yoking them together, you can get money to flow to places that if you were doing purely financial investment, you wouldn't be able to do. And if you were doing pure grant making, you wouldn't have enough dollars to match. And the way that you do that kind of magic blend is what we call a capital stack. That's how money flows uphill to things that are hard to do rather than downhill, which is the natural way that money flows in capitalism. So a capital stack is like a layer cake, and each layer represents a different trade-off mix between risk and return. So if you're just using grant money, for example, to invest in affordable housing, and you just use $2 million of grant money and you get $2 million of affordable housing, we would call that a sheet cake, one for one, flat. What we would rather see people do is take the $2 million that doesn't need to be repaid and use it as the bottom of a layer cake to help achieve the objectives or constraints that the other types of investors have. And so, for example, if you use that $2 million of grant money as a loss reserve, protecting the people who are above you from experiencing, God forbid, any loss, then they are much more likely to give you the $5 million that sits on top there because they're not worried anymore about getting paid back. So what we talk about when we talk about leveraging community benefit or other forms of grant dollars is calling into being these capital stacks, which allow you to bring different kinds of investors to the table. So how do you do that? Well, grants can pave the way to investment through these capital stacks or through outside the capital stack means, ways that prepare for investment in transactions. So outside the capital stack, how would you do that? You would pay, for example, for a market study. Would it make sense to build an affordable housing development or a grocery store in a particular neighborhood? Would that turn out to be a successful investment? A grant can pay for that kind of study. Or, for example, if you need land to build an affordable housing development, you can use the grant to pay for an inventory of underutilized properties in your city. Or a business plan for the grocery store, or similar kinds of things. So that represents ways that you can unlock investment by others, either in the hospital system or outside of it, by using grant money strategically. The other way you can do it is inside that layer cake by reducing risk or by increasing return. So the money that comes in the form of grants or in the form of cheap debt can be used to increase the return for the investors who have to satisfy that requirement. So that's enough about finance. What I'd love to spend a few minutes on now is where the transactions that hospitals and health systems might participate in, where do they come from, and how do you get more of them? And so we call that making places investable. And we have a framework that really lays out 3 simple things that have to be going on in a place in order for these kinds of transactions to be produced. So the 3 things that show up here as the colored circles are there has to be an articulation of what are we trying to do. In other words, are we trying to preserve affordable housing in the face of gentrification pressure? Are we trying to make sure that there is a grocery store in a food desert? What is it that we're defining as the most important thing for our community? And that's obviously something that's done with the community and not by any single actor in isolation. The second thing that has to be going on is there has to be a pipeline of deals or investable transactions that could add up to that priority. So if the priority is affordable housing, then the deals should be affordable housing. If the priority is small business or something else, then the deals should be in accordance with that. That's the pipeline. And then the third thing is that when we think about getting money to flow uphill, there are all kinds of contextual factors like policies, institutional practices, relationships, who talks to whom, platforms for collaboration, data, that are all piece of what we call the enabling environment. And we think it's really important for actors like health institutions to get involved not only in the shaping of the priorities and in the construction of the pipeline, but also in influencing the context in which those individual deals happen. And that's the enabling environment. So by focusing on the system rather than on an individual deal or transaction, you can both increase the scale of investment that's happening in your community, and you can make sure that that investment has the intended impact. So just a minute more on shared priorities. What we're looking for when we talk about this is that there should be a community-endorsed vision that is, on the one hand, broad enough to matter, and on the other hand, it's specific enough to tell you if $10 million landed on this community, where should it go? And it's always challenging to make those determinations because we love to do all good things for God's children, but that's not how investment works. And so driving to specificity is really important. And so when we're talking about the community-endorsed vision, sometimes the starting point for that can be a community health needs assessment, or it can be a set of listening sessions that any stakeholder, a community foundation or the hospital itself conducts with the relevant stakeholders. But it should be something that comes from a process rather than something that just appears from on high. The next is the pipeline. And what we find sometimes is that when people start thinking about the social determinants of health, they identify one transaction and they fall in love with it and they think that that's going to solve the whole problem. What we find instead is that it's good to think of deals kind of in batches so that you're not doing the laborious task of stitching together these different kinds of money. You get it done and then you rest, but rather you're tackling a group of deals that all together really make a difference. And so when you see the pipeline as a whole, you can prioritize, you can see all the potential opportunities and how they might interact. You can be more efficient in the use of your time and resources. So that's the pipeline. There are different stages in the development and execution of a pipeline. The hospital and health system doesn't do this work alone. It works with developers, it works with intermediaries, it works with philanthropy and others on the different stages of this deal, and depending on what the conditions are in a particular community, it may be more or less important to intervene at a particular stage. But when you think about the investments system in your place as a whole, trying to figure out where are things stuck, where might we make a difference if we were to get involved, goes beyond just the we're going to put money into a deal, but rather we're going to think about the system and how we can help. And the same is true on the enabling letter. If we think about all the ways that we can shape the context, maybe what we need to do is help get data, do a market study, as we were saying, or inventory the land. Maybe we can foster some relationships, bringing together actors that don't normally talk together. Maybe we can bring in a bank that we have a relationship with, or some other kind of stakeholder that could be playing a constructive role in advancing community health, but maybe hasn't shown up yet in the way that they're needed. So this is just kind of a set of the actors that are often involved in community investment. We don't think that everybody needs to be at the table all the time, but as you look at the opportunities to make a difference on community health and community investment in your place, you might think about who is actually doing work already, who might you talk to get up to speed about what's going on, and on the flip side, who is missing in action that you might be able to help engage. It's very common in these situations to see a particular kind of actor called a community development financial institution. You see them there under intermediaries. Those are often the people who bring together the suppliers of capital, the investors, with the people who are going to use that capital, like developers or small businesses. And they have a great deal of expertise in stitching together the different kinds of resources that we discussed earlier. So I'm just going to breeze quickly through some of the lessons that are coming out of our program, and I know John is going to talk about that a little bit more. But what we find is that people sometimes think that because the transition from volume to value is at such an early stage, that this work is not happening or is premature. And what we're finding is the future is here, it's just not evenly distributed. So the 6 institutions that you see listed here who are participating in the program that we're running are all folks who have used their resources of various kinds to invest upstream in the social determinants of health, primarily in affordable housing. They are each tackling a geography that's in their footprint that they've chosen to focus on for the purposes of this program. It's not the only place that they're working, but it's a place where they're working with some energy and focus. And you'll see that it's different kinds of places, cities that are growing fast, cities that are losing population. This work really can happen anywhere. What we're doing in accelerating investment is we're taking the people who are the recognized pioneers of this work, and we're trying to figure out what it would take to deepen and accelerate their investment so that they can actually light the way for other kinds of institutions that want to get into investment upstream. And I think what we found is that Boston Medical Center, a safety net hospital, might have a different approach from Kaiser Permanente, that the Catholic health system may go at it quite differently than the folks like Nationwide Children's, who are a pediatric hospital. But all different types of hospitals can find their way in this field, doing things that are appropriate for their institutional strategies and for the context in which they find themselves. I think it's useful to just say what are the kinds of roles that you might think about, and I'm happy to answer questions about this if you have any. But what we found is that it's really helpful for the hospitals and the health system to think across departments about doing as many as they can of these different roles. So one is convening with stakeholders and talking about what are our priorities? Where are we? Are we operating at a scale that's sufficient? Where are the gaps? Are we responding to needs like homelessness or food deserts, or are we going to the root causes and addressing those? Are we using our community benefit dollars in ways that are as powerful and strategic as possible? Or are we largely reacting and responding, which is granted an important part of what community benefit is for, but given limited dollars, are we squeezing the juice out of every dollar that we invest? We also are interested in having health systems invest either directly or through community development financial institutions and others in deals and projects or funds that advance community priorities, whether those are minority small business development or affordable housing or preservation of housing. Each community is different. We found very often health systems have parcels of land that, given trends in getting people healthy quicker, may not be needed anymore, or they were strategic and they aren't anymore. Thinking about how that excess land could be used in the community or with the community is another role. And then the last one that I'll just mention is all kinds of efforts, not just on health policy, would benefit from the expert engagement of hospitals. So hospitals are big employers. Transit system planning, whether it's for employees or patients, is a natural place for hospitals to get involved. That has huge impact on the community. Similarly, if people recognize and act on the connection between housing and health, people can't refrigerate their medicines if they don't have a refrigerator. So having the hospital show up as an employer, as a respected influencer, can make a real difference on advocacy. So in summary, it takes two sides of a community for a health system to invest upstream. Things have to happen inside the health system. And again, I'm happy for John to address this and for us to answer any questions you have. There needs to be a champion, somebody who's going to really punch their fist through the wall to get this to happen. There needs to be some degree of institutional leadership buy-in, but we found that sometimes that precedes and sometimes it follows the work of the champion. There needs to be some sense of how the hospital works with partners, because this is not work that is best done alone. And there needs to be some kind of capacity inside the health system, either through buying some staff time or buying consulting time or working through partners, to be able to review and act on the opportunities that present themselves. So that's all inside the box. What happens in the community are the things that we talked about in terms of the functions. So there needs to be a process of priority development. There needs to be the pipeline assembly and execution. And there needs to be the enabling environment and the platform where people think about the context. And if those things get married in a way that is productive, which we're beginning to see in all of the places that we're working in AIHC, then what comes out can be really powerful. We've seen, for example, a hospital advocating with a state government for investment in affordable housing in its community, and $20 million that would not have otherwise come to the community was unlocked from the state of California. We've seen another case where, by putting together a $1.5 million guarantee at the bottom of one of those layer cakes that I mentioned, Nationwide Children's Hospital was able to unlock $18.5 million from other types of investors, and all of that money is going towards the development and preservation of affordable housing. So we're beginning to see, and John will talk about some more examples, some real difference that's being made by health systems in doing this work, and we're excited to see what you're going to add to the success. So with that, I'm just going to give you some questions to consider, which I think are relatively self-explanatory, and I hope that you will print them out and use them tomorrow when you think about how you can put this discussion into action. That's
All right. Thank you, Robin. This is John Vu from Kaiser Permanente, and I'll take over from here. And I'll spend the next 15 minutes or so just hopefully bringing to life many of the principles, tools, framework strategies and issues that Robin raised. We could spend 15 minutes on any one of these examples I bring up, but hopefully it's giving you the feel and the flavor for how we engaged on this, and really thinking through about the roles, how you engage the actors, the environment that you want to really strengthen and enable. And really, I think the bottom line message here is, how do you, as an actor in an ecosystem, really help catalyze greater action? Because, as big as some of us are, or some of us aren't so big, we'll never have enough of the assets to really attack these issues. We're going to have to partner. We're going to have to stimulate further. We're going to have to garner more attention to these issues. But when we speak, people listen. So I think that's one of the main messages I think I want you to take away from this. The other is that we were very lucky as we were starting this journey to do this kind of investment, especially in the housing space, that we came upon Robin and CCI and all of her teams and all the thinking that they had done. Because early on, they shared a lot of these things that she just went through, and it helped us kind of have at least start knowing some of the lingo, understanding how to approach it, figuring out who we may want to approach, all of that. And so I think we all benefit from what Robin just walked us through here. So let me talk a little bit about some of the things we're trying and some of the things that we've been doing and some of the things that we're starting to see from it. First off, for those that may not know, Kaiser Permanente is a fully integrated healthcare delivery and financing system. So we have a care delivery system along with sort of a health plan. And you can see here some of the stats and figures about who we are. Currently, we cover about 12.3 million members across 8 states and Washington, D.C. We're about $80 billion in revenue a year with about 250,000 or so physicians and employees, with 41 hospitals and nearly 700 medical office buildings now across our footprint. And I really like to start actually with our mission, which Robin talked about as some of the motivating factors here. And it's to provide high-quality, affordable health care and to improve the health of our members and the communities we serve. And as you all know, as social determinants have become such a given and a deeper understanding across all of our organizations and across the industry, over the last 15 or 20 years or so, we've tried to take that communities part extremely seriously and really tying the connection between individuals and communities and really demonstrating how they're tightly connected. And you can only have healthy communities with healthy individuals, but you can only have healthy individuals with healthy communities. And so that has made it really easy for us to kind of focus on these sort of upstream issues. And today I'll talk about the housing investments. And we framed it early on with kind of this notion of we're going to direct our investments to housing affordability and this idea of economic and social needs. And how do we direct the social impact investing that way? Housing affordability, small business development, financial well-being are critical factors that are the foundations for anyone's health. And if we're really going to tackle these issues, we knew we had to kind of think about investing in these sort of twin pillars. So what have we done? Around last May, it's almost literally years of discussions internally, discussions with our CFO, our Treasury Department, thinking about how we could do this. Eventually, and then the confluence of the crises and the issues facing many of the communities that we're in around housing affordability, the homelessness crisis, and inequities and other social issues like that. We eventually, our CEO just said, we just have to kind of put a stake out there. So last May, you see here, we announced a $200 million commitment to start doing impact investing. That's right around the time we were talking with Robin and say, we just announced this, now what the heck do we do? And I'm being a little bit flip about that, but that was almost actually the way it happened for us. We knew we needed to make a statement, but then we needed to rapidly get our strategy together. So we launched a few things since that announcement. First off, to address affordable housing investments, we partnered with enterprise community partners who you probably all know to free up some loan capital for affordable housing developers. So we now have a $100 million loan fund that was made available across all of our footprint. So that ranges from Honolulu, Hawaii, all the way to Baltimore, Maryland. Big presence on the West Coast, California, Washington, Oregon, and across all of our footprint. So for all the communities that we're working in and in our market, we wanted to make sort of a low interest loan product available. Since that launch early this year, we have now been able to, as Robin said, get into the capital stack with 6 deals already, 6 properties, totaling nearly 700 units. So we're starting to learn from that. And the idea here, and we have each one of our local teams working with the enterprise local team to do the kinds of things that Robin is talking about. How do you think about the enabling environment? So it's one thing to bring the fund and the money, but how do you really kind of activate and build a pipeline of activities? So we're starting to kind of get some traction there. The next thing we did was this thing called the Housing for Health Fund. You see on the screen. Again, this is with enterprise. And this is an equity fund, actually focused on the Bay Area, San Francisco Bay Area in California. As opposed to a loan, this one is actually equity capital for affordable housing developers to bring in and preserve properties. Here you see an example from a local developer called East Bay Asian Local Development Corporation, or EBALD for short. They took some of our the money from this fund, found a property, a 41-unit affordable housing property in East Oakland, and was able to take our capital and quickly acquire the building to protect it from being snatched up by a developer and being flipped to high-end condos or whatever else. And Ibaldi now has the commitment to keep it affordable, keep the rent low for the next 20, 30 years. And so that's one way our money is being activated. And again, we're building a pipeline here in the Bay Area for this fund, and we've got about 8 other deals in the pipeline that hopefully will reach about actually preserving 1,000 units. So those are sort of 2 big vehicles we got going right now: the big loan capital fund that I talked about, and then this equity fund here in the Bay Area. In addition to that, as we were launching this, a group came together called Partnership for the Bay's Future. It was started by the Chan Zuckerberg Initiative and that foundation, and they put up the money that Robin talked about earlier to be sort of first loss leaders, a major grant to say, if we were part of the first stack, how else could other investors come in? And that really drew our attention. And now we're a major investor in this $500 million fund for the Bay Area, just because the problems are so acute and big here in the Bay Area around housing and homelessness. And this is actually going to be able to have several vehicles. It's going to have equity fund, debt capital fund, pre-development, preservation, and all of that, and faith-based land acquisition, if we can work with sort of faith-based entities. So we're pretty excited about what we can learn and develop from that. So those are some of the sort of the major fund investments. Surrounding all of this, like Robin mentioned earlier, could we bring some grant money? Could we bring other assets? Could we bring convening power? Could we bring think about our land? And in all these instances, we've got all of our internal partners working with us on that. One of these key assets is around our voice and our platform and advocacy. So along with sort of the funds, we knew we had to do major systems level change. So we partnered with this group called the Mayors and CEOs for U.S. Housing Investment, and now I think there are about 27 mayors in this across the country. And it's a public-private partnership, red and blue mayors, bipartisan thing to lobby for more federal action and funding for housing and homelessness activities. So this is literally a group now that's on the Hill, working with legislators at Congress to free up more funding, activity, and grants and innovation for these kinds of issues. I want to provide a few more examples here in the closing minutes around some deeper, how some of this stuff really activates at a local, deeper level. Robin mentioned the Accelerate Investments for Healthy Communities cohort. We're one of the 6, and we chose for this one to focus on this thing called the Purple Line Corridor Coalition, located in Maryland. The DC Metro line is expanding, and this purple line, as you see here in this graphic, is going to connect a couple of counties, Montgomery and Prince George's County in Maryland. And that coalition had the foresight to say, and the wisdom to say, as this purple line comes up and new transit stops, it's going to be very attractive to developers around retail, around housing, all of these issues. And we don't want to do it and gentrify and displace people. So how do we think about making sure that there's enough housing investment? So our local team here is working closely with the coalition, working closely with CCI and Robin and her team to think about how do you create this pipeline of housing investment that's really going to point to this idea of shared priority that she talked about that's so important at the get-go to really develop the housing that's going to be needed along this corridor. Another example, as we looked across the homelessness issues, 6 of the top 10 highest rates of homelessness cities in America are within our footprint. So we couldn't ignore the issue for much longer. So we found this organization called Community Solutions, and they're Built for Zero model. They're in 75 or so communities across the country, 15 of which are already in our footprint. So we said, let's be a national partner with you to attack the homelessness from a systems issue and thinking about the inflow and the outflow of how people enter the homelessness system. And how do you think about downstream and upstream effects here? So again, we're bringing all that we can and tying then the affordable housing investments to this effort where addressing the immediate issues of homelessness. But at the same time, we're working with the city and county leaders to strengthen their data systems, think about a dynamic approach to addressing the issues, and then tying sort of upstream all the way to downstream. One other example I'll provide here is from Oakland. The homelessness issue has become worse and worse here. A 43% increase since the last count of homelessness this year. And we have been kind of thinking about, yes, we can kind of keep giving grants to shelters. We can kind of keep giving grants to support services. But what can we really do to sort of stimulate and jolt the system here? The city and the county players and agencies and the nonprofit and support services. So we came to them and said, what if we commit in 2019? So part of what we found out in working with them was that there was a very vulnerable population, people 50 and older with one or more medical conditions. So that's a pretty high-risk, at-risk population that are living on the streets. And we found out that there were 515 people like that by name that we found out. We said, what if we commit in 2019 to housing those 515 people into some permanent housing situation, find a provider that can do this. You can see their name here, Vax. But we're going to use that as a major down payment to bring the city and county players together, the elected, the housing authorities, so on, health and human services, substance abuse, mental health, all of that to say, no, we need to build a shared priority here. And we need to point to a North Star that says, we can kind of keep funding, placing people, but what is it going to fundamentally end chronic homelessness, especially for an older population like this? So we launched this. I'm happy to say that by next week, we're going to house these 515 people. And we have done the enabling environment work that Robin talks about in terms of how do you think about the data system, connecting all these agencies, building the shared priority, thinking about the permanent supportive housing units that are needed, thinking about the landlord ecosystem here, thinking about scattered housing and other kinds of housing. So the players are coming together. It's a slog. It's a slow, kind of tough task, but we're trying. And we're thinking that this could be a model that we're thinking now. We're starting to talk to the leaders in Portland, Oregon, for instance, and 3 counties that want to come together there. Through this effort and some of the attention that this is getting, the San Diego county officials have called us and said, to come help us partner here in San Diego and San Diego County. The lieutenant governor of Hawaii called and said, can you come here and can we think about an entire island, like say Maui? What can we do there? Or Oahu? What can we do to really address the housing and homelessness issues here as an entire ecosystem? In addition to kind of the purple line example I provided earlier. These are, and in Denver, the mayor of Denver now wants to talk. So as we kind of have done this, we're getting kind of the right players calling us to say, how can you come and bring some of the assets that you have to help and work and partner with us here. So that's really just again, a flavor and some really kind of a real quick drive-by here of some of the things we're trying. You'll notice that I intentionally sort of, in my slides, used headlines from different publications because I think that's an important part of this is, again, the catalytic nature of this. We'll never have enough money to fund all the housing that's needed. We'll never have enough grant money to support all these services and sustain them. But how do you kind of stimulate others to kind of get attention? And it goes everywhere from, all the different kind of publications that have paid attention to this. You can see here, even the National Housing and Rehabilitation Association, mainstream media, modern healthcare, all these places are starting to see the kinds of things that we in healthcare can do and drawing attention to that. So we're hoping that this builds greater action. Just quick examples of that. After we announced in May, later in the year, Microsoft announced $500 million for housing investments in Seattle. Google announced $1 billion for the Bay Area. Wells Fargo then earlier this year announced $1 billion that they want to invest in their communities. So we're hoping that a movement actually is kind of building, and through webinars like this and Robin and her great work and spreading the word and providing the tools and the framework, we want to kind of keep advancing the mission here. So thank you.
Great. Thank you, John, and thank you, Robin, so much for sharing all of this information. Before we jump into questions, and again, for folks on the line, you're able to enter those into the Q&A box, and we'll try to address as many as that we can. I just want to do a quick shout out for everyone that might be thinking, oh no, my footprint isn't quite as large as Kaiser's. We got a great message in the box from a small critical access hospital in rural Vermont mentioning that they are partnering with their local CDFI and banks on these type of investments, and that you can still make an impact no matter what size you are. So thank you again. As we turn to questions, one did come in asking if anyone has any non-housing related examples of community investments, for example, investments in business to create good paying jobs.
Robin, this is John. I could give a start on that. And you saw that when I initially framed our investments, it was about housing and business and jobs. And so we are going to start modeled after actually our friends at Permanente, who have a fund like this to help do corridor investments for small businesses, small business lending, and then financial training and opportunity centers for individuals. So that's one example of what we're doing.
Yeah, and following on the ProMedica example, so ProMedica has actually invested in a grocery store, and there's another hospital participating in our program that's about to do the same in their community. So the food area, I think, is one that is obviously very central to health and therefore a really good target for this. I think the reason that people see housing as such an important starting place is not only that the clinical impact of that is so important on health outcomes, but also that if you look at the community investment sector, investment in affordable housing when it's well structured and sound is really a great investment. There's not a lot of risk in it when it's done properly. It produces financial returns, which makes the CFOs happy. And so it's kind of the gateway drug to community investment, if I could put it that way. What we have seen is there are health systems that are thinking about what kinds of contributions they can make to advancing small business and creating good jobs. And I would say that the ways to do that are not only through investment, but also, for example, by reviewing the procurement policies of the health system, what's often called the anchor mission. There are often opportunities to buy services, anything from catering to snow removal, from local small businesses, especially those owned by African Americans or Latinos or other minorities. And that's an important way of generating contracts and income for those businesses. So it doesn't have to be only through investment. Another way that we've seen this happen is that hospitals can make strategic location decisions. And so, for example, they might take a master lease on the floor of a building and then sublease those spaces to tenants who are small business owners who maybe would not be creditworthy and would not therefore help that building get built in the first place. And so there are creative ways that go just beyond the straight investment in a business that health systems can consider. The thing that makes health systems sometimes reluctant to do these investments directly is that there is a normal amount of churn in small business sectors. You know, businesses succeed and they fail and they move. And so not all health systems want to get involved in that kind of direct investment, but there are other roles that health systems can play.
Great. Thank you, Robin. Before we wrap up, I was curious, John, if you were talking to someone just starting out on this journey, what sort of key piece of advice would you give them?
Great question. There's a lot of advice. And frankly, not just because Robin's on the phone here, but having kind of the framework, we didn't even know what we didn't know. We didn't know the lingo. We don't know how CDFIs work necessarily. So the sooner you can kind of start educating yourselves on the players and the ecosystem of this, the better. And then the internal work around finding the champion is a big deal, and convincing leadership buy-in around this is imperative. Just because you're going to need to bring in lots of different players, and if you're coming from community benefit and community health, especially, you just won't have unless you just happen to have the experience, but you just don't typically do this kind of work.
Great, thank you. And Robin, any last words or comments that you would give to hospitals and systems that may reach out to you on this topic?
Sure. We wrote a paper a couple of years ago, which we're in the process of updating, for the Robert Wood Johnson Foundation, which pays for a lot of this work, about the different roles that hospitals and health systems are playing in this field. And you can find a pointer to that on our website or on the RWJF website. There are also resources that we're happy to make available. I think those are going to pop up in a minute. We're happy to talk to people who are interested in being on this journey. We're on the conference circuit and working with a number of folks to get the message out. I think the parting words would be, this is not work that has to be done alone. You should find partners inside your institution, but also we found that folks like John have been very generous in sharing their experience. And sometimes there is no one better to convince a reluctant actor inside the institution than somebody who plays the same role in a different institution. And so I would say reach out to peers, reach out to other stakeholders in the community investment system like CDFIs, philanthropy, and public officials. And together we're going to make it happen.
Thank you.
It helps also when you say, I spoke to health system X, and you come back and you tell your internal colleagues. A little competition helps too.
Wonderful. Well, a huge round of applause and thanks for both of you for joining us today. As Robin mentioned, there are a number of resources out, both from the AHA as well as CCI, on this topic. You can find them in the links on this slide as well as in the files pod at the bottom of the webinar. And for those that have asked, the presentation has been recorded and will be shared post-event. If you're interested in other resources on related topics, I invite you to check out the Association for Community Health Improvement, an affiliate of the AHA, as well as the AHA's Population Health website, where you can read more about our population health framework. And lastly, if you like this conversation and discussion, we encourage you to save the date for the ACHI conference this June. There'll be a number of conversations and breakout sessions on similar topics. Thank you.
Thank you, ladies and gentlemen. This concludes today's teleconference. You may now disconnect. Speakers, please hold the line.